what's called a clinician scientist. I take care of patients, and then as I learn from patients and questions come up, we then investigate those questions and try to answer them using data derived from our patients. You just end up needing more and more expertise that you don't have, and it's all around you. So I've been very lucky because of colleagues and collaborations both here at Mass General, in Boston, around the country, around the world, because you're just everywhere you look, you find motivated, bright people who are really driven by the same passions, which are to figure out ways to help patients suffer less and ultimately prevent that suffering. For years, so I'm a neurointensivist, for years I have taken care of patients with the worst of the worst head injuries and their families. And many don't make it, and many do make it. And for those who do make it, I'll then care for them over time. And what has struck me is how challenging recovery is. And it's not just challenging because of the effects of the brain injury, but it's challenging because of the effects of the experience of the injury. And so about 6 or 7 years ago, we started a program to see what we could do to, first of all, understand the psychological consequences of being in an ICU and then recovering, both on patients and families. And then as we started to understand things and realize how common these psychological consequences were, half of our patients were suffering from anxiety, depression, or post-traumatic stress, along with their family caregivers. It became clear that this was an opportunity for prevention. And so that's what got us started. And actually, it's a really terrific story of collaboration with psychologists and psychiatry, and recruiting really talented investigators to really take on this project and to take it over. And so as we watched the impact we could have by bringing mostly behavioral interventions, the teaching patients, or if we couldn't, at least starting with their family members, teaching them skills to prepare them for the course ahead. So that's been sort of the story of our science, and that's what's driven our science, whether we were studying brain imaging in patients, whether we were studying the epidemiology of patients and their long-term clinical course, as we call it, how often our patients would develop deterioration over years, whether in their cognition, the way their memory, or the way they could organize their lives. And we also were able to turn to genetics. And to do that, we had to recruit a global consortium to study the genetics of stroke risk and stroke recovery. Or in the case of, with working with psychology and psychiatry, behavioral interventions. Now we're really focusing on what's called implementation science. How do you take what you've learned and try to actually facilitate the change in how we care for patients, and how do you integrate brain care into primary care? And then, of course, there's the extraordinary bench science that's going on, both here and elsewhere, that we can speak to, and the investigators conducting that science are very close collaborators of ours. What drives my passion is being in a position to leverage scientific discovery and the just tremendous fun of working with intelligent, committed people, all of whom are bringing their all to solve the challenge of reducing human suffering by tackling prevention, by really thinking about what could we do so that what we're seeing today might never happen to the next generation.